Alterations in oxygenation, upper respiratory disorders. The average person is going to develop 3 to 5 upper respiratory infections annually that have the potential to develop into something more serious. Now, rhinitis is not one of your core curriculum issues, but because there is such a high prevalence of rhinitis, I like to include this in your presentation. Rhinitis is also known as the common cold. It's inflammation of nasal mucous membranes or mucous membranes. It can be acute, chronic, or may have an allergic basis. It is most commonly caused by the rhinovirus through inhalation or contact with contaminated items. Allergic rhinitis is caused by a hypersensitive reaction to allergens. These clients may have sneezing, nasal congestion, rhinorrhea, which is that clear nasal drainage, a sore throat, watery eyes, cough, low-grade fever, headache, aching muscles, and malaise. We treat it with antipyretics, decongestants, antitussives, saline gargles, saline spray, or antihistamines for allergic rhinitis. Nurses need to educate clients on prevention and minimizing potential complications, especially hand washing. Gerontological considerations, rhinitis can be potentially serious in the older adult, and they should seek medical care if their symptoms do not resolve within 7 to 10 days or breathing is compromised. Client teaching should be done on over-the-counter or steroid medications because they may have undesired effects. Now again, sinusitis is not part of your core curriculum, but there is a high prevalence, so I'm going to at least review it with you. It's also known as rhinosinusitis. It's inflammation of the sinuses and it's classified according to its duration. It does occur most often in the maxillary sinus. These clients experience headache, fever, pain over the affected sinus. That pain might be relieved if they put pressure over that site. Nasal congestion with a postnasal drip, and this can lead to a cough. They may also have pressure around the eyes. We treat it with saline irrigations, and I'm not talking like your ocean spray where you squirt saline up into your sinuses. I'm talking irrigation such as with a neti pot. Antibiotic therapy, vasoconstrictors, or nasal corticosteroids. Surgical management might be done for chronic sinusitis. There's a procedure called the Caldwell-Luke procedure and an external phenothymoidectomy, which are more radical treatments to help remove diseased tissue and alternate drainage or provide alternate drainage openings. Postoperatively, we would observe for repeated swallowing because that's a sign of potential hemorrhage that we're not actually seeing. Optic nerve function assessment should also be done. Obtain the temperature every 4 hours and assess for pain over the involved sinuses. Administer analgesics as indicated and place ice compresses. Avoid straining or nose blowing for 10 to 14 days. Nurses should encourage mouth washes, humidification. We need to keep those tissues moist, increase fluid intake, nasal decongestants, and antihistamines as ordered. Nutritional recommendations would include vitamin C and zinc whenever the symptoms first start. So which of the following statements made by a client with sinusitis would indicate to the nurse that further teaching is required? That is D. I will put ice packs on my nose 3 times each day. Again, pharyngitis is not part of your core curriculum. However, it's part of some of the other issues that we're going to discuss, and it's something you need to be familiar with. So pharyngitis is frequently associated with rhinitis or upper respiratory infections. Sometimes we see it with sinusitis, where we have that post-nasal drip. It causes irritation to those tissues. So basically, we see an inflammation of the throat, and it can also be caused by viruses or bacteria, such as group A streptococci or strep throat. And strep throat is the most serious. It can lead to cardiac or renal complications, such as endocarditis, rheumatic fever, and glomerulonephritis. It is highly contagious, and it's transmitted by inhalation or direct contamination with droplets. These clients have a sore throat. They have dysphagia, fever, a headache, and white or exudated patch over the tonsil area, and swollen glands. We want to get a throat culture, and then we'll treat it with antibiotics. Saline gargles are also very good at treating some of this with, it helps relieve the pain. Tonsillitis and adenoiditis is another very common issue that we see, especially when we're talking about our children. It is most common in children. It comes from a primary infection in the tonsils or the adenoids, or from a secondary infection from an upper respiratory tract infection. A chronic tonsillar infection, we have partial upper airway obstruction, a chronic adenoidal infection, and maybe otitis media, which is the infection of the middle ear. These clients have sore throat, they have difficulty or pain with swallowing, fever, malaise, enlarged adenoids, nasal obstruction. You may hear snoring when they're sleeping. We treat it with antibiotic therapy, analgesics, again, saline gargles. Really important to encourage these clients to continually sip on something to keep their throat moist, because it hurts more when that throat dries out. Surgically, tonsillectomy and adenoidectomy, or TNA, is recommended for clients that have repeated infections, sleep disorders, a chronic tonsil enlargement, and repeated otitis media or hearing loss. Postoperative care includes an ice collar, and ice is going to relieve that pain and help with edema. We need to monitor for vital signs, do those warm saline gargles, ice chips, cold fluids, monitor for bleeding, and remember, frequent swallowing can be a sign of bleeding down the back of the throat. So, question. After a client undergoes surgery to the upper respiratory tract, the nurse should monitor the client for most important thing is that patent airway. Laryngitis. Again, this is not part of your core curriculum, but it does happen quite often, especially with pharyngitis, your tonsillitis, etc. This is inflammation and swelling of the mucous membrane caused by upper respiratory infections, excessive use of the voice, allergies, and smoking. These clients are unable to speak above a whisper, or they have aphonia, which is a complete loss of the voice. Their throat is irritated, dry, and they may have a non-productive cough. If that hoarseness lasts longer than 2 weeks, a laryngoscopy may be indicated, because a persistent hoarseness is a sign of laryngeal cancer. Medically, we encourage voice rest. We treat or remove the cause, and if the cause is bacterial, give antibiotics. Nurses should always encourage smoking cessation. Again, obstructive sleep apnea is not part of your core curriculum. However, this is such a common issue, especially in the United States these days because of our pandemic of obesity. Obstructive sleep apnea is recurrent or frequent episodes of upper airway obstruction and reduced ventilation. It may be central, which is a failure of the brain to signal the body to breathe, or obstructive, or complex, which is a combination. These clients snore loudly. They have cessation of breathing for at least 10 seconds. Then they awaken suddenly with a loud snort because of the hypoxia. They have daytime fatigue, a morning headache, an inability to concentrate, and forgetfulness. They may have a sore throat, enuresis, which is voiding at night, and erectile dysfunction in men. We diagnose it with polysomnography. Risk factors for obstructive sleep apnea is obesity, cigarette smoking, older adults, and it can include hypertension, and it increases the risk of stroke. We treat it by encouraging the client to lose weight, cease smoking, eliminate alcohol, and use special pillows. Some clients require a continuous positive airway pressure, or that CPAP, or maybe even the BiPAP, which is the bilevel positive airway pressure. Surgically, we can do a uvulopalatopharyngoplasty, endotracheostomy, but surgical procedures have not been proven that effective, so that would be kind of a very last-ditch effort. Nurses provide reassurance, adequate instruction, and explanations, self-help groups, and counseling. Laryngeal cancer is usually caused by carcinogens such as tobacco, alcohol, pollutants, chronic laryngitis, and acid reflux. These clients may have persistent and/or progressive hoarseness, swelling or lump in their throat or neck, dysphagia, and weight loss. We diagnose with a laryngoscopy, biopsy, CT scan, MRI, or a PET scan. Surgically treated may also include chemotherapy and radiation along with that laryngectomy. Nurses assess for hoarseness, dysphagia, dyspnea, burning in the throat, their anxiety level, coping strategies, ability to communicate, and aspiration prevention. Laryngeal speech is often used after a laryngectomy. We may talk about esophageal speech, which is regurgitation of swallowed air, and then they form the words with their lips. Some of these clients may use the artificial or electric larynx, which is a throat vibrator that's held against the neck, and it projects sound into the mouth. They can also do a tracheoesophageal puncture, which is a surgical insertion of a prosthesis. Very important to assess for psychosocial issues such as social isolation, promoting that positive self-esteem, encouraging social relationships, and finding support services. I'm sorry, I skipped over tracheotomy and tracheostomy, but I'll talk about it. A tracheotomy is a surgical procedure that makes an opening into the trachea itself. It is usually used in obstructed airways. A tracheostomy is a surgical opening into the trachea in which a tracheostomy or laryngectomy tube has been inserted. It can be temporary or permanent. Very important to monitor vital signs, breath sounds, assess for color of the skin, level of consciousness, and mental status, airway patency. Monitor that stoma and secretions and provide routine tracheostomy care, suctioning, and elevation of the head of the bed. So with the endotracheal intubation or ET tube and mechanical ventilation, we use this with respiratory difficulties or the inability of the client to maintain an open airway. Mechanical ventilation can provide negative pressure or positive pressure. This is what we call the ventilator or respirator. Nurses need to monitor vital signs, ABGs, your SaO2 readings, monitor the client's mental status, their confusion, agitation, auscultation, suctioning, humidification. We may need to provide alternate methods of communication. Some of these clients with mechanical ventilation will require sedation, so very important to monitor that also. In addition, if they're sedated, they're not going to be moving, so we need to provide for potential skin impairment. So we're repositioning frequently. Now, each ventilator or respirator is going to be different from facility to facility, and sometimes even within the facility. So it's important to know your machine and know what your alarms sound like and what those alarms mean. When do you need to call respiratory therapy? And respiratory therapy should be the ones that are basically monitoring the ventilator long term. They will usually be the ones to make the changes on the ventilator in a lot of facilities. They're also the ones that are really monitoring the respiratory status. How's that ET tube doing? Are we meeting appropriate levels, etc.? Recommending some changes potentially to the healthcare provider. But the nurse is going to be doing suctioning of that ET tube. They're going to be responding to the frequent alarms, etc. So very important to know your machines in your facilities.